welcome to you all. It's good to be back and joining you for another Reach Out, Reach All webinar. And in case you missed it, I'm going to hope that you didn't. It's Dystonia Awareness Month at the moment, and this week is all around centered around the theme of celebrating our community. So it is wonderful to be joined by so many of you this evening. I think it's time that we get stuck in and welcome our guest consultant clinical neurologist and chair of the British Neurotoxin Network, two-time, and I'm pretty sure this is the most important part, Dystonia UK Award nominee, Dr. Miles Humberstone. And I think everyone will agree that we are very lucky to have you join us tonight. And I will, for all of them, warmly welcome you to this Awareness Month webinar.
Well, thank you, Dana, and thank you, Dystonia UK, for asking me to be here, and thank you for everyone who's attending. As always, I get a bit of imposter syndrome when I'm sat here, but we'll do it.
Absolutely not. We are thrilled to have you. So we are going to try and group the questions for you. We may go up and down a little bit, but we'll try and keep them grouped. And we're going to start with symptoms, if that's okay with you. One person has wrote in saying, I have tremor-dominant cervical dystonia, and their symptoms have worsened steadily since they were diagnosed about 15 years ago, which would be in their mid-50s. They've also got marked tremor in both hands, as well as jaw and lip tremor, which has developed more recently. So to kick things off, as we know this is also a hot topic at the recent British Neurotoxin Network meeting, which was held just last week, how common is tremor in dystonia and how are they related?
Well, thank you for that question. Very interesting question. And thank you for asking in advance. Gave me a chance to look it up. So, however, when I looked it up, the figures that are quoted are anything from 11% to 89%. So that doesn't really narrow it down. The long and short is tremor is very, very common in dystonia. If you want to be sort of precise about terminology, you divide the tremor up into dystonic tremor, which is tremor that's involving a body part which is already involved in the dystonia, and dystonia associated tremor, which is tremor that's in a bit of you that's not obviously dystonic. But I think that's a bit pedantic, because if you look at the tremor, it's basically the same. So what the characteristics of a dystonic tremor that's set apart, let's say, from essential tremor, is it tends to be more jerky. And that sort of fits in with the pattern that you would see in a dystonic part. There's more lopsidedness to it, more twisting. How are they related? Well, it's all, to put it very, very simplistically, it's all to do with the brain sending the wrong signals to the wrong muscles at the wrong time. And in a pure non-tremulous dystonia, the brain's sending a more static set of signals to a particular group of muscles, causing the abnormal posturing. But it's a fairly steady set of signals. And in a tremor, those signals are oscillating, and so that body part moves. What causes the difference between the two, I don't think is known. But what we do know, or what we think we know, is that the primary problem is not that movement, but is a sensory problem, which is why so many people with dystonia have a precipitating injury. And what we know, if you look at the literature on dystonia, is that this thing called an endophenotype, which means that that there's a characteristic that isn't part of the condition, but that people have even if they haven't actually got that condition. If they have, let's say, a family member. So the classic one that's been described in dystonia is a temporal discrimination test, where judging two very, very close things together, the thresholds change a lot with age and across different people. But if you take a group of people with dystonia and a group of people who don't have dystonia, then on average, the temporal discrimination thresholds, or indeed the spatial discrimination threshold, 2 points very close together on let's say 1 digit, are slightly further apart for people with dystonia. And then if you take people's first degree relatives who have dystonia, so these people who don't have dystonia, then you find that about half of all those people have this slightly increased discrimination threshold. So that suggests that there's a primary sensory problem that then somehow gets triggered to manifest itself in a motor way, and the tremor and the fixed dystonias are all a consequence of that.
Okay, thank you. That was a brilliant answer. Our second question is, if you have a form of dystonia, for example, hand dystonia, are you more prone to develop another form of dystonia, such as neck dystonia?
Yes. So the majority of people with dystonia just have dystonia in one body part, but some people with dystonia, it spreads, and you gave the example of tremor earlier, and tremor is one thing that quite often does spread to other body parts. It's not uncommon to have neck and hand dystonia, so sort of a corner of the body of what's called a segmental dystonia. It's rare, other than in people who develop dystonia at a young age, for it to spread to involve the whole body.
So usually if it's someone that isn't a bubby, then or a young person, it's usually one or maybe two places, but not more generalized.
That's exactly right. And in people who develop generalized dystonia, then in younger people we think about genetic causes, and in older people we think about secondary dystonias.
Okay.
Another underlying cause for it.
Brilliant, thank you. We've been asked if being infected with COVID-19 a number of times could accelerate symptoms of neck dystonia. Interesting question.
So that's a very good question, and I don't think there's any evidence of that. Obviously, the COVID-19 pandemic caused all sorts of issues with dystonia. Mostly the problem that it's a face-to-face treatment with botulinum toxin, and we had a period of time when we couldn't actually provide that to people. But I don't think there's any evidence. What we've seen following COVID-19 are some neurological problems, some neuropathies, but I don't think. And then there have been some severe cases where strokes and that sort of thing have happened. But I don't think that there's any reports of either new onset dystonia or a worsening of existing dystonia that can't be accounted for by disruption to treatment.
Okay, thank you. I'm sure that'll make the person that asked the question feel a bit better. We're going to move on, I think, to treatments. And the first question we have for you in this section is, what is best for pain when the neck is in spasm?
That's a very, very good question. So I'm assuming from this question that we're talking about an immediate, urgent treatment rather than your regular botulinum toxin treatment, which is,
I would think so,
overall probably the most effective treatment for pain. But of course, you can't just have an extra jab when your neck's particularly bad. So the things that people tell me are most helpful are sitting with, support to the head. And this isn't just a sort of a physical support. I think it's a little bit like the sensory trick, that actually having something maybe behind your head. If you've got, typically the pain will be at the back, if you've got on the side of the torticollis. So just the sensory contact, I think, can sometimes help to ease the spasm. And then warm bean bags and that sort of thing, the sort of thing you put in the microwave just to warm it up. Heat seems to help a lot of people and ease the pain. So those those are the two things that most people tell me are most effective.
Okay, brilliant. I have to say the heat is one I hear a lot. So that makes sense to me. Do you know why heat helps? Is that there's a mechanic behind it, is there not?
So it's there are various ways it may be helping. So when you warm up an area of the body, you improve the blood flow. So if you've got a muscle that's in spasm at the back of your neck, what you get is you get a buildup of things like lactic acid and that's what cramps come from in, you know, runners and that sort of thing. So warming that area will improve the blood flow and help to clear those metabolic byproducts. But probably also the warmth itself, the heat sensation, is gating the pain. So there's this idea that many people will know about already, the gating theory of pain, where different sensations compete to get into your spinal cord, or in the case of cranial nerve, into your brain, and that one blocks the other. And an example of that many people will be familiar with is a TENS machine if you're pregnant. So just those little tingly sensations down your back from the TENS machine help to block the pain coming in. But there are other things like, you know, those the heat rubs that people have if they've got an arthritic knee, or if they've got, you know, pain, or just simply rubbing around an area where you've had a sting or something like that. The other sensations block the pain coming in, and pain is clearly a huge driver in cervical dystonia. Not just pain creating muscle spasm, creating more pain, but the pain itself probably contributing to the abnormal movement. And a good example of that, an example that I always like to use when I'm trying to explain to people what dystonia is like, and to give people, and if anybody out there needs to explain to, you know, friends or family what it's like, there's this thing called the coat hanger illusion. It's called an illusion. It's not really an illusion. It's a real thing, where you put a coat hanger on your head diagonally on, so that it's pressing on one temple. And it has to be quite a stiff coat hanger. So there's sort of the stiffer wire ones, not the very bendy wire ones aren't any good, but a stiff wire one. It has to be painful. And when you put that on, even you don't have dystonia, it makes your head twist involuntarily. So it's clear, and the mechanism of that is clearly the sensory input then driving a protective mechanism, probably, that then drives an abnormal posture. So that's an example of how pain is clearly important in dystonia, as not just as a consequence of it, but as probably as a driver of it, but also a good way of explaining to people, you know, giving people an understanding of what it's like to have dystonia.
Yeah, absolutely. Absolutely. I've not heard that one before, so thank you.
Coat hanger illusion.
Coat hanger illusion. I'm gonna try that. Okay, so on to our next question. Why might neck and arm muscles not have responded at all to botulinum toxin, and yet the frontalis muscle injection paralyzed half of this person's forehead for over 6 months?
Okay, so that's a very, very good question. So we worry about people becoming immune to botulinum toxin, but if the frontalis test works and you paralyze half the forehead, it means you're not immune. So that's one possible cause for non-responding eliminated. So there are two main other possibilities, and one very small possibility, let's say, as far as I can think, on the hoof. So the two main possibilities would be not enough botulinum toxin into the muscles.
Mm-hmm.
And as clinicians, we worry a lot about causing side effects for obvious reasons. And for that reason, we tend to err on the side of caution, but sometimes erring on the side of caution means we don't provide a therapeutic response. So one of the reasons that neurotoxin network exists is to try to provide support for people so that people can feel confident in using adequate doses. So that's the most likely cause. The second possible cause would be it's not the right muscles that are being injected. And again, that's another thing that we try to do in terms of sharing expertise. So those would be the most common things. And then a very, very, very tiny possibility that it's a wrong diagnosis. So, very occasionally, and this is very minute, and I'm not suggesting this is the case in this person's case, but, very occasionally there is a structural cause for an abnormal head posture. So one example of that might be a condition called congenital fibromuscular torticollis, where sometimes associated with forceps delivery, there is scarring of the sternocleidomastoid, and so people have a dystonic posture to the head because the sternomastoid muscle is fibrotic and scarred and can't move, but it doesn't respond to botulinum toxin because it's a scarred muscle. It's not a true dystonia. So that would be an example of that. But those are incredibly rare compared to the two causes, which will be much more likely.
Okay, brilliant. Thank you. It was a really, really clear response. We have been asked if there are any non-surgical alternatives to deep brain stimulation survey. And in this case, the person's already been treated unsuccessfully with botulinum toxin injections. And the medication, which was clemazepam, and has therefore been asked to consider deep brain stimulation, but is concerned about the risks.
Yes, so botulinum toxin has been explored, oral medications have been explored. What else is there?
Yes.
So yes, so there are lots of non-pharmacological interventions, of which you, Dystonia UK, are great champions, and there's the great website Info Dystonia, which I'm guessing probably everybody who's on this seminar knows about, with lots of other methods, sensory motor retraining, those sorts of things. But I'm guessing that those have already been explored and put to one side. So the question is, I guess, what else medical is there? There is another emerging treatment, but it's still in the clinical trial stage, and this is MRI focused ultrasound. So it's basically doing a similar thing to deep brain stimulation, but without the need for open surgery. So the way highly focused ultrasound works is it uses MRI scans to pinpoint the spot, and then it uses a focused beam of ultrasound to heat a little area of brain and create a lesion in that area. So it's sort of going back a little bit to what was done before deep brain stimulation, where lesions were surgically created, a tiny little hole in the brain to take out a circuit that was causing the problem. So there are trials that have been done in focal hand dystonia, small trials, and ongoing trials, I think, in cervical dystonia. So it's less invasive, it's less known. As with any intervention of that kind, there are potential side effects, and because it's a lesion, it's basically destroying a tiny bit of the brain, there are potentially irreversible side effects. And the main side effects of focused ultrasound treatments are unsteadiness and speech problems, and then some cases of a sort of almost a stroke-like facial weakness, usually temporary, but occasionally permanent. So it's not a it's a fairly major treatment. It needs full assessment. It needs full evaluation before giving it. At the moment, it's used for tremor. It's used for essential tremor, but only unilaterally, because bilateral, doing these lesions on both sides does carry a much higher risk, particularly of speech difficulty. But it's an option, but one which will require waiting a bit longer.
Okay, but sort of watch this space, as it were.
Mm.
Okay, interesting. And sticking with DBS, why in some cases does the severity of the dystonia mean that DBS is no longer an option?
So thank you. I saw that question. I'm a bit puzzled by it. It's not something I've encountered. So I'm assuming we're talking about it's too severe to have to need to for DBS to be indicated, rather it's not severe enough from that.
Yes.
Yeah. So I was trying to think of cases where that could be the case, and the case that springs to mind that I have my patients have found themselves in is if there's a structural cause for the dystonia. So, for example, if you have cerebral palsy or childhood stroke, it can give you terrible dystonia. But there's a general rule that deep brain stimulation is not done on people who have a structural lesion. And the idea is, I think, because if you've got a bit of brain that's already had a stroke, stimulating it isn't going to make any difference. To put it simplistically.
Yeah.
So that's the only case I can think of where that would apply, that the dystonia might be too severe. But generally, you know, the more the severe the dystonia, if it's a primary dystonia, then the more likely we are to struggle with other treatments and to look towards deep brain stimulation as an option.
Okay. And are there any treatments that can help someone that isn't eligible for deep brain stimulation due to the severity, but is finding that botulinum toxin injections are less effective in spine, neck, shoulders, and legs? And typically, I guess the question is, what kind of pathway would someone be on in that situation?
So a lot of dystonia patients just come along to the botulinum toxin clinic. If someone was struggling, then for my case, they would often be attending a movement disorders clinic and the botulinum toxin clinic, kind of in parallel. And the other sorts of treatments that we'd be looking at, if botulinum toxin wasn't achieving an adequate result, would be oral medications. So the anticholinergics, trihexyphenidyl, much the commonest one used. Other things, the benzodiazepines, you mentioned clonazepam earlier, diazepam, sometimes baclofen, although its general use is for spasticity rather than dystonia. It can help somewhat in dystonia, and then levodopa sometimes. So those sorts of oral medications are things we would look at if we weren't well, often in parallel with botulinum toxin injections. I wouldn't say we just stick with botulinum toxin injections and then look at those. You know, often people get on best with some botulinum toxin and a small dose of other treatments like oral medications.
Okay, I mean, there's a lot of information at the moment, isn't there, circulating on the web about possible new treatments for neck dystonia, for instance, including Daxxify and new anticholinergics. Do any of these offer real possibilities of improvement in treatment, and are they available currently by prescription, and are they being used in clinics?
The first thing you said, was that daxitoxin you're talking about?
Daxxify.
Ooh. Don't know what it is. There's a daxitoxin that is in development that has a longer life than the traditional botulinum toxin type A's. I don't know whether that's what's been referred to there or not. I don't know what it's.
Hold on a minute. I am being spoken to. Yes, it is. That's exactly what they're referring.
Yeah, not yet, but
thanks, Vic.
And then other anticholinergics. It's really a class effect. We use by far more trihexyphenidyl than other anticholinergics, but they're all similar in their side effect profile. the medication has to get into your brain to help your dystonia, and whilst it's there, the anticholinergic effects are going to have impacts on your memory and cause other potential side effects. So I don't really see a big difference between the existing anticholinergics. It's hard to imagine another one coming along that is going to be very different and have much stronger benefits without the side effects. So I think we're going to need to wait for another class of medication to come along, but I don't know what that is, I'm afraid.
No, that's fair, and thank you for bearing with us while we found the answer to if we were both talking about the same thing. Okay, on to the next question then. The person that has asked this has neck dystonia with their head turning to the right. They've had botulinum toxin injections twice, the first without much improvement, but the second was EMG guided, and that's helped a lot in keeping their head straight for much longer periods. They still, however, find it very difficult to turn their head to the left. Recently started working with a neurophysiotherapist who has them exercising their neck muscles in various ways to help them relax and turn their head to the left. They've asked if you see any problems with doing this and if you have any advice on ways they can improve, any other ways they can improve the muscle strength in their neck.
Okay, yes. So the first thing I'll say is be very optimistic. The second set of injections is still very early days. We always start off with small doses, minimize side effects. I usually say to people, it might take 3 or 4 sets before we get it right. So to have a worthwhile benefit, which it sounds like we've had after 2 sets, that's very encouraging. The neurophysio, it sounds as though it's doing the right thing. What we're aiming for with the physio is to improve the posture and the mobility, not necessarily the strength. Remember that what the botulinum toxin is doing is weakening the muscles that are overactive. And what we need to avoid, and what is EMG? Electromyography. So it's a machine. You can get special needles that you inject through, which have a wire attached to them. The wire plugs into the EMG machine, and the wire attaches to the needle itself. Usually there's a plastic coating on the needle all the way. No, sorry, myography, not myopathy. There's a plastic coating that goes all the way to the end of the needle, except the very tip. So the very tip of the needle picks up the electrical activity where it is, and that plugs into a machine that might be a little box size machine, or it might be a big thing on a trolley, but basically it's telling you what's happening where the tip of the needle is, and that's really useful for 2 things. One, it can tell you that you're in the muscle, so it makes it more confident that you're injecting where you need to be, and it's not outside of the muscle. And 2, it tells you what that muscle's doing. So if we use the case of the tremor, you can hear the tremor in the muscle. If that muscle's involved in the tremor, you'll hear go at the frequency of the tremor. And if the muscle is in spasm, then you'll get a lot of noise. If the muscle's relaxed, then the EMG will be fairly quiet, just a few little clicks and crackles. So it tells you that you're in the muscle, and it tells you what that muscle's doing. And both of those are really, really helpful, both in terms of diagnosis and in terms of improving the efficacy of treatment.
Brilliant. Thank you. That's a very good answer. And I love the fact you're picking up the chat as we're going along. I glance down and see it pop up, and the girls are brilliant at answering the questions there. But you were quicker than we were, so thank you. I have a question just going back to deep brain stimulation. And this is for someone, I'm not actually sure that they're on tonight, but they have had DBS previously, and when they were younger, and they're now talking about taking the device out but putting another device back in. Have you ever heard of anyone that has had double deep brain stimulation effectively? Not 2 devices, but had deep brain stimulation twice?
So We're sure it's replacing the wires, replacing the DBS probe itself, rather than just replacing the pack, the stimulator pack, or the wires.
I believe.
So DBS has evolved enormously over time. So the modern DBS devices can do lots of other, lots of fancy. They have multiple points at which they can stimulate. So it may be that the original one, I can't answer the specifics, but it may be that the original wasn't felt to be, stimulating the right bit of brain sufficiently. There have also over time been different targets for DBS in terms of the structures within the basal ganglia that might be stimulated. It's possible it's a different target. It's possible that it's replacing an older bit of technology with a newer bit of technology that can do more and do it better.
Okay, brilliant. I will take that answer away and let the person know. Thank you very much. So our next question is for hand dystonia, mainly triggered by PC, like fine motor activities like PC mouse use. Do botulinum toxin injections have much of a negative effect on day-to-day hand use, not related to fine motor activities?
Short answer, yes, it can. And this is I think the big challenge of treating hand dystonias. And most often, if it's keyboard, then it might not be the dominant hand, but for other things like writing, it's always the dominant hand, obviously. And for musicians, it may be the dominant hand or may not be. But when you have a task-specific dystonia, you're weakening those muscles slightly for one thing, but that weakening is going to affect all other things you do with that hand. So it's a very, very fine balance between relaxing those muscles enough to help the dystonia without causing functional impairment in other activities, or even that activity.
Okay, brilliant. Thank you. And a question following on from actually the EMG conversation we were just having, why isn't that used more often?
Okay, so I told you the good bits, I didn't tell you the bad bits. Okay,
Indeed.
It's a slightly bigger needle, so it's a bit sorer. That's the main thing. And because you're looking, there's a bit more, I wanted to use the word poking around. It doesn't sound very good, does it? But you know what I mean.
You're plain speaking, we like it.
Whereas with the majority of cases, the majority of people have a good response to non-guided injection, which you can do with a very, very fine needle and do a bit quicker and a bit less sore. So it's comfort. The needles themselves cost about £15 each, which that's quite a lot compared to a penny or two for ordinary needle. But compared to the cost of the botulinum toxin, that's very, very small. So the cost isn't an issue. The main issue is that it's just a little bit sorer, and so I've had people who say, please go back to the old way of doing them.
Yeah. That's fair.
So some people it makes a big difference, and some people it makes no difference. But in things like tremor, it can be helpful, particularly if you're struggling to find where the tremor is coming from. And for people, particularly the deeper muscles, where they're not obvious from just feeling the surface of the neck. So it can be very useful in some situations. And I've talked about EMG. I'm of the old guard, so I tend to use EMG. But some particularly the younger generation of injectors and a lot of injectors on the continent would use ultrasound instead of EMG, or sometimes as well as EMG. So those are the two main options for guided injections.
Yeah.
Ultrasound, EMG.
Brilliant. Thank you. A couple of slightly more random questions before we move on to sort of living with dystonia. And the first one is one of our attendees would like to know, is there a link between dystonia and Tourette syndrome?
Yes, that's a very good question. So they come under the same broad heading of movement disorders. So sort of, if you want to try to draw a line between the two conditions, it's to do with the degree of suppressibility of the movements. So in dystonia, the movements are completely involuntary, whereas in Tourette's, you can, to an extent, suppress those involuntary movements, but the more you try to do so, the worse it gets, and eventually you have to let go of it and let it happen. So I see some people who have one of the common motor tics in Tourette's is in the face and blinking of the eyes, and it can be quite difficult to draw a line between that and blepharospasm. And there are some people I see, and it's quite difficult to decide which side of that line they fall. That's people who just have a motor tic. Obviously, so people have other things that are involved in Tourette's, such as verbal tics and obsessions and that sort of thing. Then it becomes easier to say what's what. But they respond, I think. Well, in my experience, people. Well, I'm going to qualify that. People who have a very fixed motor tic, where it's always the same bit, that's it, always blinking, respond very well. People with Tourette's can sometimes have very diverse motor tics, and sometimes it's one bit, sometimes another bit. And in those people, it's very much harder to treat with, let's say, botulinum toxin.
Thank you. Interesting question, I thought. So thank you to whoever answered it. The next question is also interesting. Is it advisable for the progress of dystonia to be assessed over the telephone?
So that is a good question. I think if I had the time, it would be absolutely great to be able to phone people halfway through the cycle of injection to see how they were. And that would provide a lot of extra information for me. It would be even better if I could see them halfway through a cycle to be able to see for myself how they were. So a telephone consult can be a helpful thing. You can't obviously give botulinum toxin over the phone, and you can't see the patient. So in terms of pecking order, face-to-face consultation would be much the best. Then a video consultation, and then a phone consultation. And then as well as that, because in practicality I don't have time between, then the other great thing is the selfie. So
okay,
videos and stills are really, really helpful for people to bring along to the next consultation and say, this is how I was at 2 weeks, this is how I was a month after my injections, this is how I was 2 months, and this is how I am, how I was last week or whatever. And it's really helpful to then be able to see. It fills in all those gaps where.
Yeah. Okay. I'm checking the time. We've got 15 minutes, ladies and gentlemen. So we're going to move on to living with, just as a general topic, and answer some of the questions we've had under that sort of heading. What can someone do that is having problems sleeping due to the muscles tightening and sort of a no type of head shake? Are there any medications maybe that would help?
So that's a very good question. So, and it's one of the unfortunate things about dystonic tremors. They're often worse. A lot of people tell me they're worse when they're lying on the pillow and the head's shaking. And although the dystonia itself goes away when you fall asleep, it's getting to sleep that's the difficult bit. So there is a benzodiazepine called clonazepam, which is we use a bit more for tremors than the other benzodiazepines. It seems to be good for tremor. It's quite short acting, and it does get used for other things as a sleeping tablet. So it's one of those instances where I'd say a small dose of clonazepam, 0.5 milligram to start with, and then it could be increased if needed before bedtime, would, number one, settle head tremor and let you get to sleep, and number two, provide a bit of sedation to help you. And some people get a bit hungover the next morning, but most people are okay. Usually it's out of the system by the next morning.
Okay,
So,
brilliant. And for anyone asking questions about sleep, we did have a webinar on sleep. So if you pop along to our website, it was much like this. I think with also presentations on that one, you can catch up with it. So we go a bit more in depth with some of the sleep questions there. Next question. If dystonia has progressed and has started causing spasms while eating in the esophagus and the stomach that sometimes lead to choking and possibly being sick, what treatment would you recommend for that?
okay, so I'm going to pedal back a bit on that question, if I may, and talk about choking generally, because choking is one of the things we worry about a lot in dystonia. It's common in dystonia, but we also worry about it as a side effect of the botulinum toxin treatment. So the first thing is, the important thing is to establish, is it part of the dystonia or is it a side effect of the botulinum toxin injections, assuming this person is having injections. So the general rule of thumb would be, if it gets worse in the first couple of weeks after your injections, it may well be a side effect of those injections. If it gets better then, or if it's not affected, or if it gets worse at the end of the 3-month cycle, then it could easily be, or most likely to be, part of the dystonia itself. If it's the first thing, if it's a side effect, then obviously we need to think about adjusting the injections to avoid those side effects in future. Speech and language therapy assessment is a very important thing to help, particularly if this is something that is part of the dystonia, to help people cope with those difficulties. And then often linked into that dietetics will be involved, and it will be things like changing the consistency of food, or other ways, safer ways of scoring, chin tucking, that sort of thing, to give practical help to the person who has those problems. So those are the main things. As I said, minor swallowing difficulties are common in cervical dystonia. A lot of people have some swallowing difficulties, so it's a matter of degree. But if people are choking, then that's obviously a very, very concerning thing and needs.
Just for context, and apologies for not saying it at the beginning, the particular case of this person is that they have tetrahydrobiopterin deficiency dopa responsive dystonia.
Okay.
That's
so
for you, if that does that change anything.
So what I've said is applicable to dystonia generally. I suppose in the specific case of DRD and tetrahydrobiopterin deficiency, there would be the additional thing of, there's a specific treatment for that. Is that treatment optimal? So just a review, and I expect this has happened, a review of medication to make sure that that person isn't either undertreated or overtreated.
Okay, thank you. Right, on to the next question then. The question is, how many cases of functional dystonia are you aware of? And in fact, if I could ask you, for those who don't know, what is functional dystonia? Yes, that is the question.
Okay, so functional dystonia is quite common. Functional dystonia is a dystonia or group. It's a very heterogeneous group of people who have dystonic posturing, which is not felt to be of organic origin. It's a very, very, very difficult delineation to make, because the historical background is that it's felt to be a psychiatric problem, but we have to bear in mind that dystonia itself was felt to be a psychiatric problem for many years. And if you look at functional imaging studies of people who have what's generally accepted as functional dystonias, they're very far from normal. So these are people who have have clear evidence of circuitry within the brain that isn't functioning as it should, and whether it's clear that it's a separate thing to people who have let's say primary dystonia, where there are certain characteristic things like a sensory trick and the paroxysm worsenings in various situations, for example, eyes closed and that sort of thing, or when walking. So generally it has a different sort of look and feel to it, but there are cases where it's very difficult to tell. And generally, many people with functional dystonias respond well to botulinum toxin injections as well. So it's a very, very difficult line to draw. And I know I have some colleagues who don't inject functional dystonias, and some colleagues who do, and I do. And I think there are very, very long philosophical discussions to be had on this subject regarding our own perception of our own self and volition. That will go a long way beyond the scope of this webinar. But I think that that people who have a functional dystonia have a very genuine problem, and it is something that can be treated. And sometimes the line between those things between functional dystonia and organic dystonia is very hard to see sometimes.
Okay, thank you. That answer, interestingly enough, I think feeds really well into our next question about identity and changes of self after being diagnosed. So the person that asked this question asked if you could talk a little bit about identity crisis that people with dystonia might go through, and they talk of a bereavement of self, asking themselves sort of, who am I now? And they say that they're more than their body, but they believe many do go through an identity crisis. And even, I guess, some might go on a spiritual journey too. It shakes up your world, right? And I just wondered what your thoughts were on that.
I think that having a bereavement process when one develops an illness is a very natural and normal thing. But when one develops an illness that is of the brain, then it clearly has other, repercussions. If you develop a problem with, let's say, severe arthritis in your leg or something like that, or you maybe lose a leg, then I think it doesn't necessarily impact on the sense of who you are as much as if something is actually going wrong with your brain and it's a problem with your brain. So I think all of that is very very legitimate, and it does sort of feed back to what we were saying earlier about functional disorders and sense of self and sense of other, and I'm not sure that I've got much so that I can actually say on that point. I mean, we one of the things that Victoria has been very keen to stress and at our meetings. And one thing we are very aware of is the huge mental health burden that dystonia sufferers have. and this is part of it. And I'm very, very aware that many of us, me included, run clinics that are very time pressured, and we probably don't have the time in those clinics to address these things as they should be addressed. And when we do, finding a referral point on is very difficult from secondary care, and often those things are actually better addressed from primary care, where there's access to talking therapies as a first step in a ladder of treatments.
Thank you. Difficult question to answer, I know. So I appreciate the response on that. We've got a couple of questions left before we run out of time. Our next one is it okay to still play golf with neck dystonia, or could this cause any problems? And for context, this person says their golf is not great, but they very much enjoy being outside and with friends. And I think that kind of feeds into what you were talking about previously about the mental health journey. And I don't know, I'm going to let you answer it, but for me, from a mental health point of view, if you have something that brings you joy and you enjoy doing, that part of it certainly can only be a good thing.
Absolutely. So there are clearly specific issues, and I'm not a golfer, so I'm talking off the top of my head here. There's clearly specific issues with regard to cervical dystonia and golf, and if you have torticollis that's the wrong way around for your golf swing, then that might be a physical problem. But as a generality, do what you enjoy. The things that you do that will take your mind off the dystonia will be the best things you do. So if you're doing something that you can forget about your dystonia, that will melt it. So those things are great.
So go practice your golf swing. Whoever asked the question,
go and do what you enjoy doing.
Amazing. And our final question is, we are obviously hosting this webinar during Awareness Month, and our message throughout this month, and in fact our message always, is that dystonia matters. So on our podcast, I always ask our guests, why does dystonia matter to you? I'm going to tweak my question just a little bit. Why do you think dystonia awareness is so important?
Okay, because it's treatable and because it's under-recognized. So, I mean, it has improved. You know, I spent most of my career treating dystonia, and when I first started, it really was an absolute Cinderella condition that many GPs didn't know about it. I think you guys have done a fantastic job, if that doesn't sound too sycophantic, in getting the message out, so that, you know, we get lots more GP referrals now from GPs who recognise dystonia and refer in directly, whereas, you know, previously have, you know, people would have had to gone through a long journey to actually get to see a movement disorders neurologist. So you guys have done a fantastic job. Dystonia is treatable. It's increasingly treatable. So there are still people out there who aren't diagnosed, and improving awareness is the road to that.
Amazing. What a fantastic note to end on. And finally, thank you to Dr. Humberstone. I don't usually pay attention to the chat. I have a fantastic team who do that. And thank you to the team in the background, Nat, who's been tech, Victoria, who, as ever, just makes me sound like I know what I'm talking about, which is marvelous. But I caught this comment as it came up, and you mentioned imposter syndrome earlier. So I wanted to read this for you. One of our attendees said, this webinar has been outstanding. I feel so much more positive. The support out there is amazing. So thank you so much for giving up your time, sharing your knowledge and expertise. It has truly been one of my favorite your questions answered, and we've done a few of them. So thank you very much. Thank you to everyone that attended. Happy Awareness Month. I don't know if that's a thing that we can say. Victoria and I have had a conversation about that before, but I hope you've all enjoyed everything that we've been putting out, and we hope to see you all again soon on another webinar. Thank you, guys. Have a great night. Oh, you're getting applauded.
Oh, yeah.